I would like to ask Dr. Nishimura how to evaluate and what you do for mitral regurgitation with aortic stenosis.
It's an excellent question. The patient is, let me rephrase it, the patient is symptomatic, has aortic stenosis, needs operation, yet there's concomitant mitral regurgitation. Is that correct?
Yes, he's going for surgery for aortic stenosis, and there is associated mitral insufficiency.
Yeah.
How do you evaluate, and what do you suggest to do at surgery?
Excellent question, because you actually need to evaluate beforehand, because a mitral valve operation will substantially increase the risk of your aortic valve replacement. I think one of the major areas that one must pursue is your own direct visualization of the mitral valve morphology on echocardiography. If in fact there's an abnormal mitral valve morphology, such as flail or such as heavily calcification, then you know that there's a structurally abnormal mitral valve. And if in fact there's significant mitral regurgitation, the surgeon should be prepared for both. However, the caveat comes in is when the patient has a structurally normal mitral valve, you then look at the jet direction. And if the jet is a central jet, it means it's from non-coaptation of the central portion of the leaflets. In that situation, in the majority of instances, by replacing the aortic valve, relieving the pressure overload on the left ventricle, the mitral regurgitation will reduce significantly in severity. So we always use intraoperative echocardiography, and I may have Dr. Park comment on that. But if in fact there's a structurally normal mitral valve with a central jet of mitral regurgitation, very rarely will you need additional mitral valve surgery. And that's an excellent question because it happens all of the time.
I have a question for Dr. Nishimura. There is a number of patients with aortic stenosis who has low mean pressure gradient below 40, normal ejection fraction, but yet reduced aortic valve area. So they are called paradoxical low gradient, low flow aortic stenosis. And it seems that the prognosis in these patients are poor if they are lived without surgery. So what do you recommend in this number of patients with rather high in our clinical practice? Thank you.
It's a fascinating question because we've just started to recognize this group of patients in the past 3 to 5 years, and I don't know why we didn't see them before. But it is a subset of patients we're recognizing from the large registries now who have a low calculated aortic valve area, less than 0.8 centimeters squared, yet the gradient is low, yet they maintain normal systolic function of the left ventricle. So thus their gradient is low and their valve area is low, which means that their stroke volume is reduced. Now, the overall prognosis, as you pointed out, in the large trial says that they have a poorer prognosis than one would suspect on the basis of gradient alone. But I think the trial that we need to do, the study we need to do, is determine whether or not the reduction in stroke volume is truly due to the afterload effect on the left ventricle from the valve, or due to the afterload effect by the valve and by the periphery with an increased vascular impedance problem. And one of the things that we are all going to try to do is to study these patients with afterload reducers acutely and see if in fact we can increase the valve area. If the valve area increases by reducing the aortic impedance, perhaps their prognosis from the valve might not be as poor. If the valve area stays very low, then they probably do have significant aortic stenosis. But it's a wonderful question, and there's been a number of editorials written on it because it's a group we've just recognized and we really don't know what to do. So thank you very much for that question.
Very good comment, and thank you very much. I think you're right. I mean, the natural history of rheumatic valvular disease we saw in the study was before many decades ago, and I think it'd be good to be able to document new natural history. And depending on what part of the world you're from and other things, the therapeutic options may be different. So I think we have to constantly look at what are the dangers and what are the benefits, and we have to constantly evaluate those. But I think one big important message is that, to me at least, is that aortic valve, either regurgitation or stenosis, is a significant mechanical challenge for heart, and it has a price over time, and it should not be ignored.
Okay, thanks a lot for you. But my question regarding rheumatic heart disease with severe mitral regurg regarding the repair. Can you give us some hints regarding the repair in rheumatic heart disease? Because in Europe and in the United States of America, the most common cause is degenerative. Can you give us, please? The repair of rheumatic heart disease, repair of severe mitral regurg.
Valve disease and severe rheumatic heart disease.
That's true. I mean, we are from, at least I practice in part of the world where we don't see that much rheumatic valvular disease. And with the rheumatic valvular disease for mitral, those patients I see have always mixed stenotic and regurgitant. So I end up replacing them, but I try to preserve as much subvalvular apparatus as possible, even though it's a rheumatic. But in terms of the experience of repair, I think that we have a lot more expertise in other parts of the world where it's much more commonly seen. So we have a lot to learn, but we just don't see that kind of patients in the States.
Thanks, Alice.
Okay, thank you very much. One final question. Okay, one final question.
Dr. Nishimura, regarding patients with AS and asymptomatic patients, do you think using the peak velocity in those patients, like severe numbers like 5.5, more than 5 or less than that, would be accurate assessment for patients should go despite the exercise test, or the mean gradient would be a better assessment?
Yeah, the brief answer is this, is that the more severe the stenosis, the higher the velocity, the poorer the prognosis. And you are absolutely correct that if you are thinking about operating in the patients with asymptomatic severe aortic stenosis, it is going to be those with the velocities greater than 5 or 5.5 that I would consider. Very good question, thank you.
Okay, thank you very much. This has been a very good session. I enjoyed it personally, and I'm sure all of you have enjoyed it too. We wish to thank all of the speakers, and special thanks to you all for your participation. And I think we should thank them in the usual way. Thank you very much.